Welcome, my name is Kendall Brown. I'm the president-elect of the South Florida HIMSS chapter. Welcome to our annual scholarship or student event. Today's topic is about Six Sigma. We have some great panelists and presenters. I think we have a couple of slides to share. Vanessa, if you wouldn't mind sharing and driving those. Just wanted to tell you a little bit about South Florida HIMSS, and thank you to our sponsors. Without our sponsors, we wouldn't be here today. So thank you to KPMG, Fortinet, Nutanix, E4, Dell, CDW, Pure Storage, Connection. Just today and this morning, we added Hill-Rom as well. So if you're interested in becoming a sponsor of the organization, please reach out to any of the board members. I encourage you to visit our website as well, where you can find out about our future events. Some of those include the May 21st annual Student Golf Scholarship fundraiser, which is the golf tournament. Registration will be open soon if it's not already. The next event or webinar will be May 25th, and that's directly related to cybersecurity for healthcare and the strategy for 2021. June 10th, we'll have the CEO and CIO of ChenMed presenting. A bit of a spoiler alert, they're giving that same presentation at HIMSS National in Las Vegas. So South Florida HIMSS is very privileged to give that presentation prior to HIMSS 21, which is August 9th in Las Vegas. We have lots to celebrate at HIMSS 21, so we hope to see you all there. Our chapter won an award as Medium Chapter of the Year. Our previous president, Pua Cooper from Boca Raton Regional or Baptist Health South Florida, won Leader of the Year, and myself won Advocate of the Year. So we have lots to celebrate. If you are going to be in HIMSS 21 in Las Vegas, please make sure that you reach out and keep up to date on your emails. I'm sure there'll be lots of information about where we will be and what we will be doing at HIMSS 21. If you are interested in becoming a member, you can find out information on our website. This organization has over 1,600 members in the South Florida region, and we are an award-winning chapter, as I mentioned before. So please reach out to us if you'd like to learn more about the organization or membership or sponsorship. All of that information is on our website, but you can also speak to any of our organization members, and we'll get you what you need. Next slide. All right, I'm going to hand it over to our education chair, Dr. Stephen Bronsberg, and he will introduce our panelists for today. Thank you for joining us, and we'll look forward to seeing you in the future. Steve.
Thank you, Kendall. Thank you. So welcome to the South Florida HIMSS 2021 Annual Professional and Student Educational Event. So we're very excited about this today. Today we have got two well-seasoned presenters. These are very professional individuals who've been in the business for quite some time. Both have a wealth of experience to share with us. Both of their CVs are extensive. I can't go over the entire CV with you, but I will certainly share just a few highlights of each, and you can read up about both of these gentlemen on your own. First, we have Dr. Hal Wiggins. Few highlights. He's a Lean Six Sigma Master Black Belt. He has extensive experience in strategic planning, quality, as well as the Malcolm Baldrige Award model, if you will. Our other presenter today is Dr. Ed Popovich. Has extensive experience in business transformation and organizational performance, has experience in multiple professions, including healthcare, finance, as well as the United States federal government, as well as the state level as well. And at the request of the governor, he served as a member of the Florida Council on Education for Management, focusing on educational leadership, improving superintendents, principals, and other overall management in academia throughout the state. So with that, I'd like to turn this over to the presenters to get started. Thank you.
So I'll start. This is Ed. Hal has his screen up, so I'll have to be asking how to move forward. Health informatics, let's talk a little bit about that. The effort here, we're focusing on improvement of healthcare processes. We don't per se call it just Six Sigma here, but we want to talk about improvement in general. So our discussion will talk about some of the challenges we have to healthcare improvement. We'll get into understanding healthcare processes through mapping and some of the customer requirements. The customer is the beneficiary of the work we do. In this case, it'll be patients and their families. It could be regulatory bodies. It could be the payers, et cetera. And then how are we going to use data to improve things? So big picture for health informatics. First of all, a lot of people will look at data and say, oh, I'm just managing data. There's a lot more to it. I noticed they didn't call it health IT. It's informatics. It's about actually transforming data into information, and information is that which allows us to make better decisions and improve our processes. We want to seek to improve the efficiency, and what we mean by efficiency is minimum time, minimum effort to do things, but at the same time we want to be effective. So think of being effective as doing the right thing right at the right time. So we want to do that. We want to be both effective and efficient, and we hopefully will make better decisions to do that. Unfortunately, we have a healthcare system is broad. It's not just acute care, et cetera. Hal, you can go to the next slide. So the continuity of care through the patient journey, people come from the community, end up maybe in a hospital through emergency department. Often that's 65% of the patient's first visit to the hospital is often through emergency department. It could be through other departments, but a lot of people's first encounter with the hospital is through acute care, through emergency department. And then after they leave the hospital, they go to post-acute care. They might be dealing with clinics and physicians, and they're back out in the community. So there could be a lot of disconnects. And if you think about South Florida with the senior population, they might be coming from nursing homes, assisted living, being transferred to a hospital, come back out, have home health, could be back in the nursing home, et cetera. So if you think about the information that we need to track, it's crossing many different encounters with the patient throughout the healthcare system. I have a bullet up here about acute care facilities, in particular hospitals, are penalized by Medicare for high readmission rates. If you understand what that means, within 30 days of discharge, if a patient goes back for the same reason, the Medicare can actually charge a penalty on an annual basis on all Medicare reimbursement. So interoperability is a challenge too, because of the fact that they're going through different encounters, whether it's a physician office or a hospital or assisted living or a nursing home. Think about all the places where the data needs to be following the patients, and we're not necessarily all on the same system. So that could be a problem for us. One of the things about electronic health records you should understand is one of the original purposes of it was to be able to track transactions for billing purposes and getting reimbursed. So it wasn't necessarily to improve the process. It was really set up so I can get paid for it. Next slide. So that's a challenge for all of us. How do we take the data? How do we follow the data? How do we find the data? And we want to focus on quality. How well is our process performing? Do we have defects? A defect is an opportunity to make a mistake, whether it's in timing and quality, et cetera. So we want to avoid errors. I have a big Q definition up for you. It says meeting, exceeding, anticipating all patient and family needs and fulfilling these with no wasted effort. That's a big Q definition. So quality is pretty broad. Cost, we're always concerned about how much does it cost to do it right. Many people are concerned about how much does it cost, period. But I threw in there, do it right. Time, how much time is wasted in the process? I mean, healthcare is one of the few, in fact, maybe the only system or industry where you have things called waiting rooms. And waiting time is something that's an annoyance, whether you're waiting in a physician office or waiting to be seen in an emergency department. Waiting is considered wasted effort. People don't go rush to the emergency department to go and sit there and wait. Now, last bullet, keep in mind, there's a lot of handoffs, as I said earlier, in patient care delivery, not only between the different acute care and post-acute care, but even within the hospital, they go moving from floor to floor, emergency department to upstairs, et cetera. There's a lot of handoffs, and it's a 24/7 business in the hospital. So if you think about it, there's many different people seeing the same patient during the day, and the handoffs could be critical. Go ahead, Hal. So here's a concern we have to worry about is why are we worried about process improvement and having expertise in doing that? And you have the first bullet, we often don't know what we don't know. Hal and I have been in many hospitals and outside of hospitals and other care facilities and care delivery facilities. And often they don't understand the process. I'll give you a simple example. We, in the emergency department, we measure the door to doctor time. That's from when the patient walked in the door to when they see the doctor. Unfortunately, most systems don't actually capture when the patient walked in the door. It might be they're sitting in there, they might be waiting in line to register, and until they're registered and caught, we don't actually know what time they entered the hospital. But that's something that we want to improve because the patient experience from the time they walk in the door until when they're registered is a waiting time for them. And that lag is concerning. So we need to have some knowledge of the processes that the patient is actually experiencing. And we often don't think about that. We don't necessarily follow the patient through when we should. So we don't always have the knowledge and experience to understand what the patient experience is all about. Next slide, Hal. So now we have to say, how do we get this right? We have to have the right quality data, big Q. We want it presented in the right format so I can understand it. And I also want to be able to get the data to the right people so they can do something, make a decision with it. And I need the right amount of data, and I need it on a timely basis. So all these are challenges for healthcare. Okay, Hal? So one of the things we have to start off doing is saying, how do we understand the process? The subject matter experts, the nurses, the techs, the doctors, they're all working within the processes. Do we really understand that? So for our health informatics or IT people, we sit there and say, how well do you understand these processes and what they're experiencing? Next slide, Hal. So what we have to do is say, how do we understand, learn to see the process and understand it? If we can't see it and you can't measure it, if you can't measure it, you can't manage it. And if you don't manage it, it's hard to improve it. So we need to understand the processes. So IT people need to get out there and really understand what's going on and what the experience of not only the patient is, but the caregivers. Next slide. So let's start with a simple process map. I'm going to explain emergency medicine. If you go to the emergency department, it's very simple. A patient arrives, the patient's treated, and the patient leaves. So it's basically a three-step process. And some of you might look at that and say, that's kind of like overly simple. Yes, it's big picture, and that's what happens before the patient arrives, before the patient sees the doctor, and then during the time the patient's seeing the doctor, and after that's what happens. But we have to dive in a little bit deeper. So next slide is an example. We're going to sit there and say there's lots of gears, and we also have to worry about what happens to the patient when they leave the hospital. Do they go to other facilities? Do they go home? Do they go to home care? The care managers or case managers are concerned about the follow-up for the patients too, because they want to avoid the readmissions. And as a side note again about readmissions, the penalties could be up to 3% of annual Medicare reimbursement to a hospital. And I have data, if any of you are interested in it, I can show you 2021, the penalties even for South Florida, for Broward County, Palm Beach County, Dade County. I can show you what the hospitals are being penalized for this coming year in the fiscal calendar year. Next slide, Hal. So here's an example. This is a process map of the emergency room, and it's again very simple. The patient arrives, et cetera, they go in. But notice the bottom row, cycle time. How much time is actually spent there? Until we get in there and dive into that, we won't know how much time is being spent and how much time is being wasted. How efficient are we and how effective are we at doing what we're supposed to do? A lot of these times are not tracked in our health informatics systems. For instance, when you come in the door, unless you have something when they walk in the door, they're immediately registered in the system. That doesn't happen. And how much time they sit there waiting for the doctor. When they're in the emergency department and they're in a room, how long do they have to sit there before the doctor shows up? And then after the doctor spends maybe their 5 or 10 minutes with the patient, how long before they hear the results of what's going to happen to them? So you think about door to doctor decision, making a decision what they're going to do with them, and decision to disposition. I disposition them either upstairs and they're admitted to the hospital, or a treat to street, they go back out to the street. There's a lot of time, a lot of things that happen in this process. This is just a little bit of a deeper dive, but we need to start tracking these times, and there's other things we could track. A lot of our systems don't do that. I think, Hal, the next slide is yours, right?
Yes. First, I want to comment on this slide. We map because when you look at a process, and this is a pretty simple one, when processes get more complex, it is not humanly possible to just verbally discuss and analyze the process. Most of us are visual learners, and that's why mapping is so powerful. All right, Ed and I recently did some work at a Midwest hospital helping them improve their perioperative or surgical services process or system. And this was pretty complicated, as you'll see in a minute, because there are different types of surgery: elective, emergency, outpatient, inpatient. Scheduling, you would think, would be very easy, but it's really complicated, and it also varies by the type of surgery. Orthopedics is different than general, for example. Then you have last minute scheduling, you have add-on patients, et cetera, et cetera. Patient procedure clearance. This has to be captured. This is where you collect the history and physical for the patient, any testing information, lab work, imaging. And that's a real challenge, because if that has not been collected beforehand, together with an appropriate consent form signed off by the surgeon and the anesthesiologist, patient's not ready for surgery, we can have delays. Insurance verification is certainly a part of this. There's admissions, there's registration, all the paperwork. PACU is post-anesthesia care unit or post-op. And that's in phases. We cover that. A number of our patients go to the intensive care unit afterwards. Is the unit ready for them, et cetera? There's discharge, and then there's follow-up. So there's a lot to this, as you can see by this map here. And you'll notice down the bottom, this is version 6.1. We created this map for the senior leadership of this hospital, because there's no way we could have a discussion about everything that was involved in surgery. So we did this high-level map, and we color-coded it. The parts in blue to the left are the before that Ed talked about. Gray in the middle is the during surgery itself, and then green is after. And the arrows show the flow. And then down the bottom, you see all these boxes with the arrows going up. Those are all of the ancillary or support services that are necessary for this, and they contribute in one way or another. So we showed our first version at the senior leadership team that we set up, and they started to make changes. And this wasn't complete until we had 6 iterations of it. But this we kept bringing up at every meeting, and it really facilitated communications throughout the process. Now, this is PACU, or post-op phase 1, and you can see the complexity of this. And so if you think in terms of measurement, and then we'll talk about that later, you are concerned about how long this process takes from beginning to end, from here, the green part, until the end down here, actually, over here, right here. And there are a lot of steps here, all right? How much time? We have to understand how much time is spent on each step. And then we break it down further. Not all time is the same. Value-added time is the time spent in actual work that ultimately will satisfy the customer. Non-value-added time is waiting. It's mistakes that have to be corrected. All right? And unfortunately, there's an inordinate amount of non-value-added time in waste. We begin to understand that when we start talking about the process and the steps. Your HIT systems may not have the details needed to understand how time is spent in the process. And in fact, most electronic health records are not set up to mirror the actual processes in the system. It's generally set up as a generic process unless you actually go back and modify it to make it conform more closely to the work that you do. All right. Now, this slide shows the system from beginning to end, and it mirrors that other system map that you have. But here we are focusing on those important parts of the process where we need timestamps. So we all go everywhere from the start at booking the surgery and doing the history and physicals, all the way to the patient's first post-op visit. And we have follow-up for here. And notice, once again, we show this before surgery, during surgery, and after surgery. When we started out with this system, they did not have timestamps for all of these points. And so we had to work with them to collect it. All right. This is another map. This is urology. And this is clearing a patient in urology. Now, this is not as complex as the PACU phase 1, but notice all of the large boxes on that system map can be broken down into the steps. So there's a whole lot of steps for that whole system. And down the bottom here, this team actually started to identify the waste or the non-value added activities. And this shows areas to work to improve this phase of the system. All right. Now we get into customer requirements. And there are multiple types of customer requirements. You have the internal customers and the external. And so over here on the left, we have the who, and under external customer, we have the patient. But you also could have insurers, and you could have regulators, healthcare regulators, and then you have your internal customers. Every step in a process has customers, okay? And in fact, the customers for the subsequent step from the one you're working on have requirements for the work that you do. And what they require can be things like accurate information. You will need skilled nurses or providers. They have to be caring. One of the biggest complaints that you're well aware of, the electronic health records, they want them to be easy to use. And doctors are especially concerned about this. And in fact, a lot of them hire scribes to actually do the data input and the work with the EHR. The information and the response needs to be timely, it's got to be fast, etc. And then the customers, the generic customers, can be the patient, nurses, doctors, technicians, coders, etc. And this varies by step and varies by process. Now, we use a term that we call critical to quality, and that's basically what is important to the customer, what is critical to quality. And some of your generic characteristics are things like successful outcomes, and that's most important. Patients come to the hospital to have successful treatment for their concerns. We want skilled professionals working there. Reliability is important. We mentioned cost, responsiveness. How accessible is your provider, is your nurse? Timeliness, accuracy, completeness, very important, especially for paperwork. Ease of use, we talked about, care and concern, and safety. And these requirements will turn into actual metrics or measures. Now, why do we need data? Without data, we can't assess performance, okay? And we can't assess the critical requirements for our customers. We use it to identify variation, and variation is the relative strengths and weaknesses in our processes. If you were to look at a trend chart, for example, or a control chart, you would see ups and downs and you would see patterns. A lot of it is just common everyday variation of no real concern, also known as noise. But some of it is very significant, extremely high or low scores, for example, trends up or down, shifts, above or below the mean. And we get to understand that and look for that after a while. And ultimately, we do it to drive improvement. Okay. We have measures for the inputs. We have measures for the actual process itself, and then we have measures for metrics, the outputs. We measure inside the step, we measure between the steps, and referred to this as your transitions or your handoffs. We look for quality, cost, and time, and we measure overtime is what we do. Okay. Lastly, all of our important data has to have goals. And that's one of the things we found in this hospital system. They were collecting a lot of data, but they didn't have outcomes. They didn't have goals. And without goals, how do you measure how well you are doing? Okay. Ed, to you, and you might have some comments or anything to add to what I just said.
I'll just take over from here. I appreciate that. I have up on the screen the typical way we do problem solving. We have a real life problem, and we often take guesses or experience or educated guesses and guess at the solution. Well, let's try this, let's try that. So I'm going to give you an example. There was a hospital in the Southeast, not in Florida. They had a concern that patients were leaving. This was a hospital that saw 100-some thousand people coming through the emergency department a year. So that's a fairly large emergency department. When I worked at, I was a hospital executive at Boca Raton Community Hospital, now regional hospital. We used to see mid-40s, some thousand. So this was a hospital in the Southeast that saw over 100,000 patients. They had a trauma center, helicopter come in, et cetera. And patients would show up and they'd see it's crowded, and they'd end up leaving before they saw the doctor. And there's a danger in that because, first of all, if they're truly sick and they leave and they're trying to go find another emergency department, which they're not close to each other up in that area, the Southeast, there's a danger to the patient, first of all. They could truly be sick. There's also a cost to the hospital because they'd make several $100s on average for each patient that they treated. You know, there's money to be lost, so there's an opportunity cost. And they had a goal. They wanted to reduce it to less than 1%. In fact, in the winter time, it was not unusual to see a left without being seen, patients leave without being seen, of anywhere from 6 to 13% during the winter season. It was a high flu season. So that was a tremendous opportunity cost plus a potential liability with the patients getting injured or hurt or have a problem later. So we went in there and said, well, how do we solve this problem? Hal, the next slide. Hal? Okay, good, thank you. So not to scare any of you, I have a doctorate in statistics, so I throw everything into statistics, but the idea there is, can I gather some data from the system and say, can I say which factors made a difference? Was it how many people were in there? Was it the time of the day? Which doctors were working? Which nurses were working? Was it the day of the week? For instance, were they having more issues on Fridays, et cetera, et cetera, et cetera? So we gathered all this information and started tracking it. It turned out also the schedule, when do the people work, you know, what's the staffing levels, et cetera. So we turned it into, think about it, to a word problem like you'd had in college. You go in there, you had a word problem and you got to get the answer. So we sit there and say, if I use the formulas I learned in that chapter of the book and solve that word problem, I'd get an answer. So we did that and we said that let's just understand what's characterizing the problem. Hal, next slide. So then what we say is, can I get the answer in the back of the book? That's the solution. And it turned out we can. And we found out there were certain things we could do. In fact, at that one hospital, we tried some changes. We found out the important access. Go to the next slide, Hal. So what we did is said, let's institute some of these changes on these variables. And they said, well, Ed, we can't do this all the time. They asked me, can you just run a pilot? So we did it for 1 week at the end of February this year that we were working there. And the left without being seen for that week went down to 0%. So it went from potentially 6 to 13% down to 0%. And I remember going through the data with people, and we had to wait a few weeks because of Press-Ganey gives a patient satisfaction scores. It takes several weeks to get that. But we went from having a under 20 percentile patient satisfaction, we went to the upper 80s. People were much happier. So we had 0% left without being seen. And then on top of that, I asked people, what was our volume that week? And the IT people came back and said it was the second busiest week in the winter season. And here they were saying, well, maybe you just picked a good week and it wasn't so busy. It turned out it was it wasn't the busiest, but the second busiest week. We had 0% left without being seen. And all of a sudden they realized, hey, by following this rule, we are able to solve that problem. And we use the data to do that. So I can talk about the solutions and what the X variables are, but I go to the next slide, Hal. The idea there is there was lots of variables that went into it. And it turns out typically there's a handful of X variables, things that we were measuring on the steps, the scheduling process, and some of the other variables that we did. We found about a handful of X variables that if we just managed those a little bit better, we ended up having a better control over what was happening. And a lot of times you'll put a lot of X's in there, lots of data, but with the statistics and analytical tools that you do, the Six Sigma or anything else, you'll usually find out that there's only at most a handful, maybe just a few X's that make the biggest difference, and you can manage your problem. So rather than guessing at the solution, and by the way, the solution we came up with was not one that anybody had ever guessed at. So it's a good thing we followed this roadmap, and this is where we got. Okay, Hal, next slide. So what kind of X's should we worry about? What kind of things affect it? So we say, who's working in the process? You know, the type of clients, the workers, the managers, you know, what's going on, what's included. We have in the hospital, we have a lot of things with healthcare carts. Emergency department has things set up already, the supplies already there, what's involved. We had to look at that. When, time of the day of the week, the months, the seasons. South Florida, for instance, you know, you're very seasonal from Thanksgiving to Mother's Day. You typically have a huge influx of people from the north. So the census can be double or triple. So you need to understand that. There's tools to help you with that. And that also affects staffing. And so on and so forth. You get the 5 W's. You can read that: who, what, where, when, and why. And then how many, how often does it happen, how much. These are kind of things we use to trigger people's ideas of what kind of data to track. And it turns out a lot of the data we need to track isn't actually in the system. So we'll have to talk about that in a little bit. And Hal was talking about this hospital. Is actually a Mayo Clinic affiliate that we work with in the Midwest. And we started looking at quality, cost, and time. So you see margin and cost, and delivery and throughput, and quality and safety. And then we have culture and reputation. We looked at before, during, and after. We said, what are the metrics, the detailed metrics that people want to track? So we actually divided up the groups into looking at the metrics, and they came up with these ideas. And the next slide, Hal, it says, what metrics do we have? They were using Epic as their system. And the ones in green said they actually had the data available. The ones in yellow said we really don't, but we're in process of getting them. And red, we're not sure if we're ever going to get those. This is just a partial sheet for just the people that post-surgery. And we had to go in there with an inventory of what data do we have and what data don't we have, and how much can we get. And many of the data things we need don't always come from Epic or from the EHR that we have. Next slide, Hal. So in a sense, what we're doing is it's a retrospective exercise, meaning we're looking in the past to get an idea of what's going on in the future. But with Six Sigma and some of the tools that we talk about in health informatics, and especially at Nova Southeastern and other places, we talk about understanding process data over time. And can I look at the past to tell me what might happen in the future? Can we understand what's likely to go on? And we look for clues for the improvement ideas. We're letting the data take us there and help us improve the decisions. Of course, in many health systems, they're worried about the bottom line. How much is it costing? How much money am I making? But we also have to worry about the efficiency and effectiveness, our quality overall, make sure that we're spending time well on doing their, improving things for the patients and their families. So sometimes we need a little bit more data than we have in our systems. The input and process metrics are needed. Next slide, Hal. When we were working at this system in the Midwest, as Hal was talking earlier, we developed scorecards for the leadership level. So if you remember that big high-level process map that we talked and got to version 6, they wanted to know from a high level, how are they doing? They were worrying about data coming from cost accounting, electronic medical records, information systems. They were using Epic, and some people use Cerner or other systems out there. And they wanted to have an idea from the leadership standpoint, how are we doing in terms of strategic goals? Are we making the numbers we want to make, et cetera? But the people working in the process, need data every day, the real-time decision-making, because they're managing staff. There's people coming after PACU, which Hal didn't mention to you about this part, in the post-acute care units and post-anesthesia care units. It turns out that not only are people coming there from surgery, but they were also coming from interventional radiology, they were coming from cardiology, they were coming from gastroenterology, where they might have had some other work done separate from the surgery room, but they were all patients that had anesthesia, and so they had to go there. And with the coronavirus, they were hard put to manage and track it. They didn't even know what was happening next, and they were just putting people in beds in the different areas, crowding it up. And they said, we need to make better decisions at the right time, at the right place. And we also need to know what's coming at us a couple hours in advance so we can prepare for it, as opposed to it just all drops at our door. So the metrics that we need there at the dashboard. So think about driving your car. As you drive, you're looking for things on your dashboard. If the red light comes on or the big exclamation point or wherever you have on your dashboard, you might say, hey, there's an emergency. I want to know what's going on. You have real-time data, and that's what the hospital wants. Next slide, Hal. And Hal, I think you'll take over this one. Or do you want me to do this?
Let me jump in, and you probably will have a comment or two on it. First, I need to say something about the material that Ed covered, the breakthrough equation, Y is a function of the X's. Your typical quality improvement department in hospitals don't think this way. Now, there's, of course, exceptions. If the hospital is very serious into lean, Virginia Mayo, for example, their Baylor Scott and White is another one. They will have a sensei. This is a highly skilled person that they actually hired to work, knowledgeable in advanced statistics, or if they're in Lean Six Sigma, they'll have a master black belt or someone like Ed or myself working with them. If you don't have the more sophisticated knowledge, especially in statistics, you tend to do more simple things. Now, those things are valuable, and there's a lot of basic problems, we call it low-hanging fruit, that can be addressed and improved, but you can only go so far. And that's something that we really helped that system with, because when it came to data, they had a large enterprise data warehouse, and they pulled their transactional data from a lot of separate source systems, electronic health records, finance, et cetera, et cetera. But for the purposes of process improvement, it was not all in one data mart. And so we talked with them about that, and they assigned one of their IT programmers to us and pull data from the enterprise warehouse into this data mart. And from there, it was able to be put into the correct database formats on the desktops where it was actually analyzed. And Ed, you want to comment about the manual collecting aspect of it?
Yeah, I would add a couple of things. Not only in the desktops, the hospital system that we're talking about is putting up screens, TV screens in different areas so people can see it real time as they're working and see how they're doing and what's coming at them. And it was, again, quality, cost, and time to worry about, the load, the factors, what's happening to them, et cetera. So one of the things that became very obvious to us is they didn't have a lot of the data they needed. There was cases where we had to manually collect it. So I said, well, how do you do that? When I was in Boca Raton working at the hospital, I used to use volunteers. I used to use student interns. I used to collect data, and I said, well, you know what, even on a sampling basis, it's better to know what's going on. And even if I'm having people track things on sheets of paper or entering it on tablets, we were able to get things into people into iPads, et cetera, and track some data. That data would help us because it was a good sampling, rather than saying we don't have the data. And people's argument would be, well, it's not the system, I can't use it. I said, well, let's not let the system get in the way. If there's things we need to track, let's figure out how to do that. And soon enough, the IT people would say, well, if that's important to track, maybe we'll figure out a way to do that. But in the meantime, there's ways to collect the data through sampling, talking to people, observing. I had volunteers sitting in the emergency department and say, when did the person walk in the door? So I actually know the time. Surgery thing, same thing. So we ended up saying, how do we add that data? And some of that data, when you had subject matter experts or the volunteers or other people studying it, they'd end up with ideas of saying, every time I saw this happen, this problem came up. And we'd get ideas from those people, man, you collecting the data. So the data might not be in your system. That shouldn't stop you from gathering data, even if it's on a sampling basis.
And a couple of specific examples from this hospital: infection control, very important department when it comes to addressing surgical site infections. And that was the reason why we were brought to that hospital, because Leapfrog, which is one of the reporting agencies on quality in healthcare, dinked them for too many surgical site infections. And so that is the big why, if you will, a big outcome, and it wasn't a good one. And so now when they were tasked with finding out why they had so many infections, they had to start looking for X's, the factors, the variables that influence the outcome. And so infection control was very important in this. And they didn't even have a systematic approach. So we helped them develop an audit sheet, and they were going to actually then sample data in the ORs. And they are probably right now starting to chart that. Another example was environmental services. They were responsible for cleaning up ORs, operating rooms, and they didn't keep track of data. And the first visit they made when we were there, they actually took pictures of where they found infections and encircled them. And so they were eventually going to keep track of those errors, chart it over time, et cetera.
Al?
Yes.
So one thing you mentioned about environmental services, think about how busy a hospital is. They were turning around the room between surgeries, and every time, I think it was like $500 or $600 every minute they made in surgery. And so if they weren't doing certain things, if they didn't turn it around fast enough, they couldn't do new surgeries. But the flip side of it says, well, how well were you turning it around? Were you getting rid of the bugs, if you will, the infections, potential infections? And they hadn't sampled that yet to really check that. They were just so busy turning around, they didn't know to see how well they did. So the other thing about that with SSIs or other things, they can cause the readmissions. So typically within the first 30 days, people get an infection, site of the surgery the wound can get worse, and they end up being readmitted to the hospital. That can create penalties for the hospital. So that was all key. And we asked them what kind of data they have. And it was really more of what I saw and what I observed, as opposed to actually tracking and sampling and testing.
Okay, this is an example of one of the dashboards that they created. This was actually produced from Epic, and they started to work in Power BI. I believe that's correct. And one of the advantages of that system is that it can pull data from numerous source systems and put it into scorecards and dashboards. And the director of surgical services, a surgeon, ordered 12 large screens to put throughout the surgical area, because he felt that everyone needed to be able to see this data. And in fact, they were going to meet next to these screens when they did their huddles, looking at real data, as opposed to all too often the data is in the form of paper reports distributed to senior leaders and managers, and it might be put on the walls in their offices, but all too often just on the desk or in a desk drawer. So this is just an example of some of the data that they were collecting. Ed, any comments on this?
Yeah, one of them is take the on-time starts, and they were looking at first starts, particularly it says 57%, which means that the surgeries typically were scheduled at 7 a.m. and 57% were on time, which means 43% weren't. So a question comes up: if I'm not on time, it didn't start at 7 a.m. If I was an hour late, what would that do to the rest of my schedule for surgery the rest of the day through that surgical suite, versus it's only 2 minutes late or 3 minutes late? So now you come up and say, well, how late was it? Because when you do the percentages, you don't really know if it was just like slightly late or was it really off, and that could affect you. So percents is sort of a dangerous thing to worry about, because you don't know what the actual value is, as how late were they and how much did it blow up my schedule the rest of the day? Because if the first surgery doesn't launch on time, what do you think happens the rest of the day? So these are some of the metrics they were looking at.
Okay, and this is an example of an outcome. And Before we came, they weren't identifying and looking at factors that influenced this. Sure, they knew that some surgeons would arrive late, or some anesthesiologists would be slow to doing what they needed to do in pre-op. We found one thing very significant was patient clearance. Too many patients showed up the day of surgery in pre-op, and they didn't have their history and physical or their test information or signed consents. And the nurses had to scramble to get that information. And what happens some is one of the primary responsibilities of nurses is to administer the antibiotic in time, because different antibiotics had to be administered a specific time before surgery could begin. And if that didn't happen, there would be a delay at that transition when the patient is wheeled from pre-op into the surgical area itself. So that's something that they started to do. So they were going to have their dashboards throughout the surgical area and start talking about them. We mentioned the importance of data format, and here's where some expertise comes in. So if you look at a typical goal for a lot of emergency departments, length of stay. Common standard is patients will be seen and discharged within 90 minutes or less. Now, senior leaders, we're used to looking at the percent, and basically they will ask the question, well, what percentage of our patients were seen within 90 minutes or less? And so the percent yes, no is important to them. Unfortunately, if you collect that data in that format, which is easy to do, you will not know how close or far away the patient was. So the far better format is in the actual minutes. So we can see patient 1 got through really quick. Patient 4, 204 minutes, they were taking up residence there. And the question, of course, then is why? So the better format is the actual time itself, and it requires some knowledge to know that. Now, we talked about format for data analysis briefly. The data needs to be in a database format where the variables are in the columns and the individual patients are in the rows. If the data is not pulled out of the data mart in this format, quality people can't analyze it, and you can't produce the tables and charts that are so very important. Ed, any thoughts on that?
Yes, the thing here is to keep in mind, when we talk about the breakthrough equation with the Y's and X's, the IT people should understand that if you look at databases, the columns, which we call fields, and the rows are called records, well, the fields are actually typically Y's or X's. And so what we do is say we need to put it in this format, and each row could represent the whole patient experience, one patient through all these Y's and X's. So think of columns as Y's and X's, and the rows being maybe individual experiences or patient information.
Okay. Now, purpose of measurement, as Ed mentioned, is to turn data into actionable information. But there's 3 questions that deal with data integrity, and this is a key concern of IT. Is the data valid? Does it measure what you think it's measuring? Is it reliable? Is it accurate and consistent? At some point, you need to test your measurement system, because if you don't and it's not valid and it's not reliable, it's the same old garbage in, garbage out. Data collection reality. Data is not lying around in that finished database sheet format. And it takes a lot of effort to get it into that format that could then be analyzed. Okay, are times in the correct format? For example, most hospitals in their EHRs will have data in military time, because if it's not in military time, if it's in the more traditional AM/PM, there can be errors that come about from that. Databases will have errors. It can be just the wrong time was put in. You can have missing data. There can be duplicates, wrong formats, not on the spreadsheet structure, or missing variables. This requires a lot of data wrangling, and that is a specific expertise in and of itself. Finally, we look at the building blocks. We talked about patient satisfaction, patient requirements, the employee requirements, employee satisfaction, the role of leadership, and leadership also has requirements. Each of those three boxes is crucial because requirements turn into measures or metrics. We speak with facts, we have our process focus, and we have to have an attitude of continuous improvement. Processes fixed at one point don't stay fixed, and we can always improve them more. This is a very ongoing process. I think we have a little time for questions. Let me turn it back.
Okay, thank you. Thank you. Excellent presentation, covered quite a bit, and let's open the floor for some questions.
I have a question. This is Grant McGaw. How do you factor, what I call human factors into metrics? That's the unpredictable human behavior. How do you account for that in your formulas?
Ed, let me start with that and then you can jump in. You've zeroed in on a real challenge. Case in point, patient satisfaction. That's a very subjective human condition or construct, if you will. And we frequently design surveys to do that. And that's real problematic in and of itself. We do the best we can with it. And Ed, any thoughts as a statistician on the handling of that very complicated and complex information?
Yeah, I think part of it, if you look at Pensacola, Pensacola Baptist, they did some things there that was very interesting. I know we were involved in South Florida. I know, and I've been to Baptist Health and obviously Boca Raton as an executive. But one of the things you look at is behaviors and attitudes. So you do some sampling. For instance, when people go and talk to the patient, one of the things we learned is the behavior that's useful is at a doctor's office or whatever, for the doctor, instead of standing up over you, pulling a chair up and sitting next to your bed and talking to you one-on-one instead of staring at their watch or their iPhone, et cetera, using calming words, the words that you use, sir or ma'am, or how you're polite. I noticed I worked for the Surgeon General of the Army for 3 years. And one of the things I found was very, very interesting about how well they use the words and do things. And so the behaviors and the attitude came across very clear with the sir and ma'am and on and on. But you know what I'm talking about. So we could look at behaviors, words used. We could sample that on a basis. We used to track that kind of thing because the other thing with Press Ganey, we noticed that one of the concerns with patients and families is how well they're kept informed and how are they informed. So questions about what they're told and how they're told and in what format and where they're told are things that you can watch. Can you catch every behavior, every single words? No, but we did this by audits and sampling. Again, sometimes the manual data tracking, going off and collecting some sample data is actually very valuable because you'll hear things and you'll say, well, why do they do that? Call centers use this all the time and how you answer the phones, et cetera. So there's lots of ways to track behaviors and attitudes and how things are expressed. And we used to include that in our data.
That's very interesting. And we do have a question in the chat by Shalini. She has stated, how should students be prepared to tackle these challenges during their study? Having some real case scenarios and coursework would greatly help, perhaps.
Let me address that. Or Ed, you want to go ahead?
Yeah, I know, again, going back to my time in South Florida and at Boca Raton Community Hospital, University of Miami started also a program many years ago. I helped get it started on Lean Six Sigma. Howard Gitlow is a professor there. And I used to have his interns. I had actually at one time 6 interns come in and work with me. And they did that in the process of completing a project. So they had, if you will, it's equivalent to what NOVA does. It's like a practicum. You go in there and do an exercise. And I worked with them. I got them on a project. I was their sponsor. I evaluated them, and I actually got them in real life problems, and they get to see the process in place. And so I had 6 at one time. At any one time, I had 6 people working for me. It was also a cheap labor for the hospital, for Boca Raton. Being honest, it was cheap, but it was also valuable. And I think the students left, and many of them ended up in healthcare somewhere else, and some of them ended up at Boca Raton Hospital. So I think giving them at real life practical problems and getting them out there in an internship in the summers and all that is good, and sometimes off during the regular school year. So I'm a big believer in those practicums and practical experience and linking up with some of the executives and actually going out there and getting involved and seeing it firsthand.
Let me give a practical example of this. In the informatics program at NOVA, where Ed and I are adjuncts, students can take 3 classes in process improvement in healthcare from beginning all the way to advanced. And we incorporate case studies in that. And at the advanced level, and not too many students go that far, but it's available, they actually have to do a live project, and we encourage them to incorporate that into their practicum. So that is a real opportunity that they have there in the program.
Okay, excellent. Great presentation. We had some wonderful questions at the end. We are really at that time, so 12:59. I think we believe we should be ending it right now. And just a few comments before we end the session for today. If you are not a member of the South Florida HIMSS Association and you are interested, we really encourage you to become a member. We have ongoing programming throughout the year. We have different projects going on. We are very much involved with our community here in South Florida, and it would be nice to have you on board working with us on some of these unique projects. So thank you. Okay, let's end there and have a wonderful day.